Good evening, everyone, and thank you for joining us for tonight's clinical webinar, How to Apply the Holladay Report in a Cataract and Refractive Clinic. Our speaker tonight is Dr. Jack Holladay. Dr. Holladay is currently a clinical professor of ophthalmology at Baylor College of Medicine in Houston, Texas. Dr. Holladay received his medical degree from the University of Texas and holds a master's degree in electrical engineering from Southern Methodist University. He is the author of 3 books, hundreds of chapters, over 100 articles in peer-reviewed scientific journals, and also holds 12 patents. Dr. Holladay is on 5 medical advisory boards, has received many awards, and is well known nationally as well as internationally. It is definitely an honor to have Dr. Holladay here tonight to talk about the new Holladay Report. So without further delay, I'd like to welcome Dr. Jack Holladay.
Well, thank you, Chris. It's good to be here this evening, and it's a pleasure to be able to talk to the listeners about our Holladay report. We've been working on this thing for at least 10 years, and I think what you're going to see tonight is actually the culmination of all of that work. And we're going to talk to it specifically related to the cataract and refractive surgeons. Okay, and these are the financial disclosures that I have, and the only one that's really relevant at this point is OCULUS, as we'll be talking about the Pentacam. Now, the other thing is that I've gone to a lot of trouble to make this very easy for you. So I put together a handout which you can get from Oculus, or there's also one at docholliday.com down at the fourth one that you see there. So you can just click on this particular Pentacam Holladay report, and it'll give you a summary of all of the stuff that we've talked about tonight. And also they have this presentation available for you, so you can go through that with the audio and actually listen to the discussion that we have yourself at your own pace at home, looking at the slides and listening to the audio. Now, the version that we're talking about today is version 1.20 revision 69. And there's some specific things about this one that I want you to know. So you can get that from Oculus in terms of them doing a remote session and downloading it and installing it for you, or actually giving you the executable itself so you can install the software. And one of the first things we did on this version, which is the number 69, is that before you had to actually go through and set the main color bar to get the right settings. And on this version, the Holladay report, every single surgeon out there, when they pull this up, will see the same map for the same patient. We've got it set so the sensitivity is right, the colors are right. There's a lot of things that we'll talk about with those, but that way you'll find that it eliminates all of the problems that you might have because you ended up with having the wrong settings. And this example really shows that. When you look at this, what you see is that the map, as we'll talk about today, green colors are good. And if everything's green, basically it's a normal patient. And what you see here is all of these colors on this patient are absolutely green and absolutely normal. The problem is the settings the surgeon has chosen were all wrong. They chose the core settings. They used the Kleist absolute scale that goes up to white and pink. They have colors that go down to purple and large scales. And so even though this looks normal, I'm going to show you the same thing with the recommended settings on the Holladay report. And it's this map right here. That's the same exact map that you were just looking at. And what you'll see here is that this map basically is the same map that we saw that's all green, but the settings are right. So now when you load this, you won't have a problem any longer with the scale, the sensitivity, or any of the other things being correct. Now the next thing is that you also, even though there's a Holladay setting on there, you don't need to worry about that anymore, and you don't need to lock it on the Holladay setting. When you load the map, it'll come up correct. You can click on the map, right click, and change things, but I don't recommend that you do that but basically it eliminates all the problems we've had of getting different maps with the wrong settings. It also sets the map overlays, and that is we'll see that the things that you want to see are the apex, which is what we call vertex normal. It's where the light reflex is. That's shown by a white circle with a black dot. It also shows the thinnest location with a little circle that you see here. We also see that it shows the posterior, the pupil center, and shows the pupil edge. But all those settings are set. And then over here, what we see on this side is, again, that on elevation maps, we don't need all of those things. So all of those settings are chosen for you, so you don't have to worry about it. Now let's go through step by step, looking at the report itself. There's 2 pages, and this is page 1. Now what you'll see in the upper left-hand corner is the demographics. You're able to put in details about the ID and the description of the patient, so you can put certain comments and things if you like. The central upper area on the map is what we call the EKR readings, and these are for the cataract surgeon. What they do is they give you the flat EKR 65, which is the flat K in the axis. They give you the steep EKR 65, which is, again, the steep axis. It gives you the mean K, gives you the astigmatism, it gives you the Q value for that zone, and it also gives you the spherical aberration for that patient. And we'll talk about those values in a minute. But all of those are important because today, what the EKR 65 does is gives you K readings and astigmatism that reflect the front and the back surface. So you don't have to add the against the rule astigmatism that's present on the back of the cornea because with Scheimpflug, with the Pentacam, it measures the back surface, so that's already included. This spherical aberration term that you see here. Well, the spherical aberration term, as we know, we can get aspheric lenses today. And the lenses are like the AMO is plus or minus 0.27. The Alcon lens is about minus 0.18. And the B&L lens is 0. So if you have a patient, you can look right here at this Z4, 6, and 8 because Doug Koch has shown that you really want to use all of the spherical aberration to determine the lens. And when you look at that value, what you see is this 0.398 just says that you should be using the highest negative spherical aberration IOL you can get because that matches that patient. So the point is the K readings and the spherical aberration term tell you the astigmatism, the K's for the IOL calculation, and the spherical aberration of the patient. And those K's don't need to be modified by the back surface because they've already been included. Now, the other things that we have up there are going to be shown on the next map. But basically, the vertical that we see here, this vertical curve or vertical column, is actually the topography. Gives us the front and the back surface of the topography. The middle column gives us the thickness and the corneal pachymetry values that we'll talk about. And this final column over here actually gives us the elevation above a toric ellipsoid that we'll talk about a little bit also. Now, the first thing that we look at when we look over here in this first column is the sagittal curve, or what we call the axial power map, is the one that we usually are used to looking at for K readings and stuff. And the first thing that you want to look at are that those red and blue semi-meridians form a straight line. And what you see here, it's pretty straight, but a little oblique here, and fairly straight on the left side, but a little bend here. And all that tells you is this 1.31 diopters of astigmatism here in that 5 millimeter zone is pretty close, but we also see that those two are not perpendicular. They're not orthogonal. So this patient has some irregular astigmatism, And the tangential curvature map is even more sensitive. So even in a normal person, you're going to see some moving around of that on the tangential map, but it basically is even a more sensitive measure of the geometry of the cornea. So you want to look at that. We'll see some examples of that in a minute too. When you look at the corneal thickness map, these little parameters that we have here, this white dot with a black dot in the center, the white circle with the black dot, is vertex normal. The plus there with that little white plus behind it is the pupil center. And then this is the thinnest part of the cornea here, that little black circle. And that basically in a normal individual, this black circle, the thinnest point of the cornea, should be temporal to the light reflex and a little bit inferior. And we'll see in a minute that all those dimensions are given in the upper right-hand corner. When we look down here on the relative pachymetry map, we know that the cornea is a negative meniscus lens. And that means it's like a negative powered contact. It's got a steeper back surface than front surface, so it's thinner in the center and it's thicker in the periphery. The reason the cornea is positive is because it's got water behind it. If there were air behind the cornea, well, it's actually a negative lens. But the point is that the thickness of a meniscus lens is predictable. It goes up by the square. And so we know what the thickness increase is. So the relative pachymetry map tells us what the thickness of the cornea is relative to what it should be at every point. So these values that we see here, this is a normal person, are about 2% thicker than normal. These are about 1%, and we see that they're all fairly within plus or minus 2%, so this is normal. But it's the thickness that it should be at that point relative to normal. Now, the elevation map is the elevation above a reference surface. Now, for many years, I did this back in the 70s, we used a sphere as the reference, but the cornea is not spherical. It's not shaped like a basketball. The cornea, the nearest shape to the cornea is a rugby football. The cornea has a nose. It's steepest at the center. It gets flatter as we go to the periphery, so it's like the nose of a football, an American football or a rugby ball. And then if we have astigmatism, one meridian is steeper than the other, which is the flatter. So it's like the end of a rugby ball that has a nose and it's got a steep and a flat meridian that are orthogonal. So if we use that, what we see is we can have a flat and a steep meridian, so it's toric, but we can use an ellipse to fit that. And then what we see is what the difference in the shape of the cornea is relative to the normal surface. And that's what it is. It uses a fixed ellipsoid and it fits to that surface. And this is the back surface, basically. Same thing. Now, these are fairly normal, so I wouldn't worry about it. So we just want to show you the normal values here. Now, we made a bunch of tables, 12. There's actually 13 there, but the thinnest pachymetry was duplicated. So there's 12 separate tables that tell you what the average value is, the mean for each of these values, and then what 1, 2, and 3 standard deviations are above or below the mean, depending on the parameter. Now, you don't need to know all of these values, though, because what we've done is we've designed the map so that if it's 2 standard deviations, then it's going to be in the yellow zone, and if it's in 3 standard deviations, it's in the red zone. So you don't have to look at that. You don't have to memorize those tables. One of the things that we made since the symposium presentation was the change in that upper right-hand corner to give you some additional values. We have the pupil diameter, the location of the pupil relative to the light reflex, the corneal diameter relative to the light reflex, the pachymetry min relative to that light reflex, and then we have the depth of the anterior chamber. We call it the external anterior chamber depth because it's from the corneal epithelium to the front of the lens. as opposed to the internal, which the glaucoma guy used from the back of the cornea. And this is the one that we use for IOL calculations. So all of the parameters that we talked about are up here. Everything's the same. And the only other thing that we have up here is the ratio of the back to front and the quality of the image. So the normal cornea's back to front ratio should be 82%. And the only reason we look at that is in refractive surgery, that changes a great deal. And the farther that is from 82%, the more you have to be a little careful of the K readings. And then the pachymetry min and its mental, where it's located relative to the light reflex. And then chord mu is what you used to call angle kappa, although it was really a chord length. And it's the distance from the center of the pupil to the light reflex. And the normal is about 0.3 of a millimeter. And we'll talk more about that in a minute too. But notice here on this picture that the vertex normal and the thinnest part of the cornea, that the thinnest part of the cornea is temporal. And in this patient, it's almost 0.8 of a millimeter inferior and about 0.75 temporal. Now, this is a normal patient, but still those dimensions are at the upper limits of normal. All right, so as we look at the second report primarily for cataract surgeons, the K readings that we recommend using are K readings in the 4.5 millimeter zone. And it's just because the studies have shown those correlate best with back calculations that give the least prediction error. The astigmatism, as you see here in this patient, is 1.31 at 4.5 millimeters and 1.38 at 3 millimeters. Well, that difference of 0.07 of a diopter isn't going to make any difference. So what you see is that the K readings don't change much. But if you had a pupil and this person had a large pupil, I mean, their pupil was 7.15, and that's because they were dilated. Now, number one, you shouldn't do that. You shouldn't put dilating drops in a patient and then get the measurements for their topography because they're wrong. It changes the tear film, it changes the shape. So what should happen is they should have had those tomography measurements before the patient ever gets any eye drops. And then you come back, but that just tells me it's too large. And anyway, so what we were looking at was the shape, the size of the pupil was far too large for this patient. And as we looked at it, what we saw here was, and let me go back and get to where we were, that in this person, basically, again, with that 1.31 diopters of astigmatism, that's a pretty good number. The K readings are good. And this little map just shows us that the distribution of the power varies from 40 to 42.5 over that 4.5 millimeter zone. And this is pretty normal. This is pretty normal. All right. So now let's look at the next patient. We look up here and we see K readings of about 42, 59, and 68. Almost no astigmatism. Spherical aberration is not there because my unit was not calibrated when I took this picture. And you have to have your unit calibrated by OCULUS in order to be able to get the spherical aberration term. 83.3% is good. The patient didn't blink. It's a good map. But you notice here, when we look at this map, that the thinnest part of the cornea is not temporal relative to that light reflex or the pupil. It's almost straight down. And it's about 1.07 millimeters down. Now, we'll talk more about that because this chord mu, this angle kappa value, if it's ever greater than 0.6, the performance of diffractive multifocal lenses is not good. The pupil is too far from the optical center or the pupil, and so that pupil center to the vertex normal, if it's over 0.6 of a millimeter right here, well, that value is it's just too large to be able to get good performance with diffractive optics. So when you see a value more than 0.6, you want to sway away from using a diffractive multifocal lens. All right, so we see that this is down. We look down here and we see that this is yellow, 4.6%, and we notice that it's about 7% where it trips into a problem. On our topography maps, we look here and we see that there's a little red zone down here, but it's at 49, so it's a little steeper than it should be. This is 9 microns above normal, and this one's 25. Well, that tells us right there that the 12 to 15 was the value where it was abnormal, so this is way over, so this is definitely a keratoconus. It's not suspicious, it's definitely keratoconus. But it points out a couple of things. First of all, it's common for the elevation on the front surface to be less than the elevation on the back. And the reason is that the epithelial cells are about 4 to 6 layers thick. There's about 4 to 6 epithelial cells that make up the epithelium, and they're about 6 to 8 microns thick. So you got about 50 microns of epithelium. But if it protrudes or you get a little ectasia, you have a bulge basically, then what happens is the upper lid rubs off those epithelial cells in that area where it protrudes. So what's happened here is you've had 1 or 2 epithelial cells rubbed off of the front surface, and that can't happen on the back surface. So the result is the back surface is a much better indicator of a cone than the front surface. Now, here's the other eye. We look down here and we see that red spot. We see another red spot. We see that that thinnest part now is way below. It's 1.34 millimeters, so this is a big trigger. 6.1%, 13 microns, and 38. So clearly, when we look at that, that patient has keratoconus. I mean, there's no question about it. And the right eye was right at the level of detection, but the left eye is over. And it just illustrates to you then the things that we want to look at are the location of the thinnest point relative to the pupil center, the location of the relative pachymetry thinnest point and what it is at that same area, and the posterior elevation. Although we can look at the front, that's the one that counts. And then on the curvature maps, this red spot down here, and you see that that red spot is fairly round, which is typical of a cone. So those are the 5 things we look at. The red spot on the topography maps, the inferior displacement of the thinnest point relative to the pupil, the thinness on the relative pachymetry map, the elevation on the posterior, and the elevation on the anterior surface. So that's clearly a keratoconus. Now, here's another one. Let's see what we have. Well, first of all, it's certainly not steep here. We see some steepening out in the periphery. We see a steep spot right here. And we're going to talk about that in a second. We see that the thinnest point here in the cornea, the center of the pupil, and the light reflex are all very close together, and it's 35.8% thinner than normal. We see that on the anterior elevation map, it doesn't show much. It's actually a little bit low. And then on the posterior map, it actually has about 14 microns of protrusion. Well, that 14 microns of protrusion, that elevation is showing a very mild ectasia. So this would be somebody that you'd want to do cross-linking on, because that elevation already shows you that it's bulging forward in the back. Now, it's only gotten to orange, but it's going to get worse. Now, the other thing that's important to see here is most of our treatments today are centered on the pupil. So you're going to see that that thinnest point that's normally a little inferior and temporal moves up to dead center, because we actually make the thinnest part of the cornea in the center of the pupil if we treat on the pupillary center. So that's just another characteristic that shows it. But basically, the ratio of the back to front now is 63%, because that front surface is so much flatter than normal that the back surface is only 63% of the front, not 82%. And we see that the K's, so these K readings here would be the ones that we use. We look on this map and we see, well, the patient, when we go back, we see that his pupil size was 2.94, so it was about 3 millimeters. Now, this is pretty typical because the light's pretty bright when we take the measurement. So 35, 35.50, and 35.27. So we see that that's almost 4/10 of a diopter flatter on the average. The astigmatism didn't change much. It went from basically 0.1 to 0.4. But if I were putting K readings in, and I see that the axes, Let's go back and look at those. If I had to do cataract surgery after I cross-link on this person, we'll look at these semi-meridians. The 3 mm zone is different than the 5 mm zone. It's all over the place. So I can tell you right now, even with that little bit of astigmatism, the patient's got more irregular astigmatism than regular. And I would probably scoot down a little bit, use Ks of 35, 30, and 23 as the K readings because his pupil is so small. All right. Now for IOL power calculations, the EKR65 basically is better than net power because what it does is it converts and compensates for what the back surface of the cornea is. So if we had a front surface of the cornea that measured 45, but the back surface was 3/10 of a diopter steeper than normal, so that it's minus 0.3 compared to a normal, well, then we would report 44.7. But net power, the Pentacam gives you net power also. Now, net power is what every IOL formula today converts K readings to. And it's about a diopter flatter than a K reading. But if you take the net K reading and then you convert that and put it in an IOL calculation, it reduces it again. So you end up double compensating for the change between the K reading and the net power of the cornea. So the EKR compensates for that, changes the K reading to what it should be based upon the back surface and the front surface of the cornea over that 4.5 mm zone, but then converts it to a value that you can plug into any IOL formula today without worrying that you're double compensating for net power. So when we look at this, here's another patient that we see has an oblique astigmatism. The Myers are not orthogonal, so we're suspicious of that right off the bat. They have 1.76 diopters. Now, when we go through and calculate the astigmatism of 1.76, we fit this to the best we can using orthogonal Myers. And that's what the toric lens will do. The toric has a steep and a flat meridian, and it can't fix oblique astigmatism. So you know that you're going to have a residual irregular astigmatism with this, and you need to prepare the patient that they're not going to come out 2016 or maybe even 2020 with this kind of cornea. Now, when you look up here, you see they got 0.308 microns of spherical aberration, 81%, so they haven't had refractive surgery. We see that the center of the pupil, the light reflex are all close. We see everything looks good here. There's no problem on our elevation maps. And the chord mu is 0.29. And all that means is that it's less than 0.6. So we don't have to worry about the performance of a multifocal lens because angle cap is so big. But we might have to be a little concerned about that person because their astigmatism is not fully correctable. And so if they have a little loss of contrast sensitivity from irregular astigmatism and the multifocal lens, well, a lot of times they'll complain of halos and waxy vision and not be happy with their vision. So those are the K readings that we would use, and that 0.308 is the asphericity that we'd use, or the spherical aberration. So a minus 0.27, the AMO Technis lens, would be a good lens for this patient because it would correct that. And these are just a blow up of those values that we just discussed. So these values that are in that upper box, plus that chord mu, are values that we use for cataract surgery. All right, now let's look at another patient here. All right, see a hot spot over here and a hot spot there. That's not typical of anything that we're used to looking at. All right, we look over here and we see once again that center of the thinnest point is about 0.8 millimeters, so that's much lower than average, about 7.1%, about 11 microns elevated, and here it's 19 microns. So in this patient, and 7.1%, which is yellow. So that hot spot lines up with the relative pachymetry map, and it lines up with that elevation. And it lines up with where the displacement of that thinnest point is. So that's a keratoconus patient, no matter how you look at it, because of those four things that we just saw. Now, one thing that's important in lens calculations, you may not do anything on this patient. We'd do a corneal transplant, you might do cross-linking, but what you find is in a patient with keratoconus, they actually have what's called a bimodal distribution in power. They've got this 45 diopters, which is the steep part right here, and then they've got another one down around 40. Well, that bifocal cornea is like a bifocal intraocular lens or a bifocal contact lens. If you had a +5 bifocal contact lens in which the base curve of the contact corrected you for distance, and that little 5 diopter cap was something that you would look through for near, what you would find is when a patient looks at a distance, they're looking through the paracentral zone. They're looking through here. They're not looking through that cap, but if they take a near card and hold it at about 20 centimeters in front of their eye, well, they'll be able to read J1 plus because they're looking through that bifocal. So the point is, you don't want to use the average power in here for an IOL calculation because the patient doesn't look through the average of 40 and 45. He looks nearer 41 diopters for distance, and that cap up there is not beneficial for anything that they use practically unless they want to see microvision like a microscope when they hold things close. So the point is the EKR takes that into account. And you see that even though the average is going to be up here at 45 for that peak, the EKR is down here around 4250 for the value that it uses. And so that 4250 is taking a lower than average for that power. All right. Now, all that boils down to is that the EKR 65 is valuable for post-refractive surgery, PKPs, keratoconus, corneal scar, basically any situation where you have irregular astigmatism, the cornea, the EKR 65 is going to give you good values for that. Now, a couple other things that we see, as we pointed out, in the normal individual, the peak power and the spread is very small. This is a normal individual. It's about 3 diopters like we saw. In a LASIK patient, that spread goes up to about 5 diopters because we don't reshape the entire cornea properly. And in a post-RK patient, that thing's almost 13 diopters of spread. So the point is that the ability to predict the corneal power in an RK patient is worse than it is in a LASIK patient and is worse than it is in a normal. For a normal individual, we can get down to a half a diopter. In a LASIK patient, it's about 1 diopter is the standard deviation. In an RK, it's almost twice that. So you just need to prepare the patient that you're going to have more variability in the outcomes, and you might need to do a touch-up with a laser. You might need to do the touch-up with a piggyback lens, but you prepare them that they might have to do an adjustment. Now, again, when we look at those, always look at the semi-meridians to see that they line up. This person only has 0.65 diopters, but if you used a lens that was like a T3 to correct that, well, you'd realize that they're going to have some problems because they have an irregular astigmatism. Here's somebody that has a fairly normal distribution, but thinner in the center. This is a post-LASIK patient. Little elevation, but not enough to worry about. Same as on the front of the cornea, and their cord view is 0.5. So again, we would use the K readings that we have right here on the EKR 65. You see they have a pretty small pupil, so we'll look at that. That's zonal power, or the spherical aberration of 0.472. That's typical in a post-myopic LASIK. They're always going to have more spherical aberration than a normal, so the highest negatively aspheric lens you can get is always the best. Now, again, we see that they have a little bit of a bimodal power here, that little double peak, and we see that the Ks go from 3943 to 3920, so I'm not worried about that small pupil because there's only about a less than 2/10 of a diopter drop in their power from the 4.5 to the 3 millimeter pupil. All right, so these calcs just show us that if you use the keratometric mean of 40.2 as opposed to what the EKR65 was of 39.1. These are real cases. The patient came out +1 and they would have come out plain O if they had used the EKR65 on these patients. And we see these all the time. So the EKR65 is the value that you want to use. And if the patient has a smaller than average pupil, then you might want to scoot down to that 4 or 3.5 millimeter zone. So what we've tried to do then is show you the values that we get using the EKR65 and why we recommend that for the calculations. And basically on the ASCRS website, it's got net power. And so what will happen is if you use net power, you're going to come out with powers that are so low that you're going to basically over minus the patient, so they'll come out a little myopic. And if you use the EKR65, you can run those in your standard IOL calculations. So let's open it up for questions and see if we can answer any questions.
Thank you, Dr. Holladay. So for questions, you have a text box on your screen for questions. If you enter those in, I can pass those along to Dr. Holladay. Also, if you have a button there to raise your hand, if you have audio and you raise your hand, I can unmute you and you can ask Dr. Holladay directly. So I have a question here. Holladay.
Go ahead. Read it to me because I don't see any questions. Go ahead and read it to me.
Is there a spot on the ASCRS calculator to put in EKR65?
No, that's what I was saying. That what they did is, and I'm going to talk to Warren about that. What they have is a place on there for net corneal power, and that's because the study that Rick Popkin published in February of this year showed that the EKR65 was the best. But if you optimize the constant for those 19 patients, that you'd come up with a pretty good result for the true net corneal power too. But the true net power is low. When you put that in, it's going to compensate again in the IOL calculation, so it comes out about a diopter less than it should for the corneal power, which means you over minus the patient. So you don't need to use the ASCRS website if you put in the EKR65. That's what the point is.
Okay, so I have another question here. What is the specific difference you see to differentiate keratoconus and PMD?
Well, that's good. And we didn't show any pictures of those, but let me show you an example here. In fact, what that would look like. That's a good point. And that basically what would happen is this. I don't have a good case of that, but I do have an example here that'll help you see what.
Dr. Holladay, I actually have a PMD demonstration patient that we could use where there's no patient information being shared. If you want to do that.
Is it the yeah? Let's switch over to yours. Is it a it's on the version 69 map?
Yes, it is.
Okay, yeah, put it up there. Let's switch over to you and let's look at it.
So let's take a look here. We have the Pinacam.
Okay.
And we have a PMD patient.
Mm-hmm.
And then this is one specifically where the PMD is fairly severe in the left eye, and then it is less severe. And I'll go ahead and hand you control if you want to demonstrate.
No, that's okay. Just flip it over to the Holladay report here, and let's look at that. Okay, that's good. Perfect.
So this is the severe case again, just to let you know.
Yeah. Well, let's look at this one first, and then we'll look at the less severe. But what you notice is this. On the sagittal curvature map, you see what we call a crab claw. And that is that these little pinsars that come together, that this thing looks like a crab claw coming around, because basically the cornea is thin way out of here in the periphery. And so what happens is it sort of bulges up just before you get to the limbus, and then it drops off and gets a very steep area. So you've got this very steep arc out here, and the actual tangential map is a little bit more accurate in where that curvature is, because you see out here it gets real steep and then it flattens out again right here. So this is a crab claw, and this appearance of a crab claw are almost diagnostic of PMD. Now, when you look here, look how much farther that thin spot has moved relative to where it was on normals, which was up here within the pupil. What you see here is the center of the pachymetry map is 0.67 down and almost 2 millimeters temporal. So the thinnest point is way out of range of where it should be. And then on the relative pachymetry map, we see that down here in this zone where we see the maximum curvature change, down in that same place, it was actually thicker here, and it gets real thin way out here in the periphery, which is why it's peripheral marginal degeneration. And then finally what we see is in that ellipsoid fit, that in that zone where it's bulged out in the corner, that ellipsoid fit shows you that elevation is way, way above what it should be, because in this area where there's a very steep curvature, where it's become ectatic and becomes steep, it's also bulged out to where that elevation is far above the toric ellipsoid. So the hallmarks of PMD then are the crab claw shape on the topography map, the significant twice displacement of the thickness towards the periphery, a corresponding relative pachymetry change in the periphery, and an elevation that corresponds to where the steep area and the thin spot were in peripheral marginal degeneration.
Excellent. So the questions are actually kind of lighting up here. So we'll take a few of them.
Go ahead. We can go keep going. I don't see any questions. I guess
I can send them to you if you like.
No. Just go ahead and read them to me, and let's go.
Is the general consensus is the general consensus that you want to achieve a post-op spherical aberration of 0, or is it better to have some spherical aberration for depth of field?
You know, that's so confusing for people, but you never want to have residual positive spherical aberration. Now, I know George Bico and those people, and I've convinced them and showed them, and then the next day they start talking about it again. But here's what happens. Spherical aberration is just the property of light rays in the periphery not coming into focus where the paraxial rays are. So there's no question that if you have zero spherical aberration, such as the pilot studies we did with the Technus, those people that came out with zero had 2012, 2016 vision uncorrected. And their depth of field was actually better at plus or minus a half a diopter than anything else. And that's because the peak was higher. Now what happens is if you're going to have residual spherical aberration, you want it to be negative. Because what happens to the pupil when you accommodate and look up close? It gets smaller. So negative spherical aberration is when you have more power in the center and less in the periphery. And positive spherical aberration is when you have more in the periphery and less in the center. So what you see with positive spherical aberration is night myopia. Patients are ametropic during the day. They go out at night, their pupil dilates, the spherical aberration kicks in, and all of a sudden they're nearsighted. Well, you don't ever want that, because when they get back in and they use a bright light, it comes into the lower power, so they lose power when the pupil constricts. With negative spherical aberration, and we showed this is why hyperopes who've had LASIK have better near vision than myopes, because they end up with a lot of negative spherical aberration. And anybody that does refractive surgery knows that hyperopes love the near vision that they have when they're in their 40s and 50s because they have perfect distance vision and they can read. Whereas a myope will lose some of that reading vision. So optically, no spherical aberration is the best. And optically, because the pupil constricts when we look up close up, a little residual negative spherical aberration is beneficial. But positive spherical aberration is not any good except for night myopia. Next question.
Okay. So do we use EKR to also determine magnitude of the toric IOL?
Yes. Yes, and you use that astigmatism there. In other words, when you look like there on this patient, now we wouldn't be doing it but this person that we're looking at had a 3.5 millimeter pupil, has 4 diopters of astigmatism. Now you're not going to put a toric lens because his looks like a crab claw and there's a lot of irregular astigmatism. But let's look at page 2. Click on details up there for me. All right. And what we see is he has 4 diopters of astigmatism at the 4.5 millimeter zone, but 3.28 at the 4 and 1.77 at the 3. Now that we knew that because look at that power distribution down there. You know, his cornea is all over the place. So the answer is yes. The EKR65 astigmatism is the best value for what you want to correct. Now, let me say one more thing, though. It takes into account the back surface of the cornea. But for cataract surgery, there's one other thing that we'll be publishing pretty soon, and it's this. That the cornea, even with a near clear temporal 2.5 millimeter small incision, over about 6 months, ends up becoming a little flatter vertically and a little steeper horizontally. In other words, there's an against the rule drift in the cornea that's not there preoperatively. So what I tell people is you put 0 into your IOL calculator for the SIA. In other words, you don't put in a 0.3 that you're going to get steepening at 90 for a temporal incision. You put in 0 because you're definitely not going to get any with the rule that's there 6 months. But you will get a little against the rule. So the rule is that basically you use this astigmatism that's on the EKR, but what you should target for is a 1/2 diopter of width the rule. That is a 1/2 diopter axis 90. Because what will happen is if you target for that, by the time 6 months rolls around, between 3 and 6 months, their cornea will have flattened in that vertical meridian and they'll be spherical. The Baylor nomogram basically says that because what it does is it says add a 1/2 diopter to against the rule and subtract a 1/2 diopter from with the rule. Well, that's the same thing as targeting for a plus 1/2 diopter of with the rule in your calculation. So either run the calculation with the EKR65 and add a 1/2 diopter against the rule, or subtract a 1/2 diopter with the rule, or when you look at the printout, just look down and target for that plus 50 at 90. Now, the other thing that people are confused about is don't flip the axis. That's absolutely wrong. You want a spherical cornea when you get done, and you're not going to give the person a pair of glasses. That going from with to against the rule is only true if you give a person a pair of glasses. The blur that you see with a 1/2 diopter of with the rule is no different than it is with a 1/2 diopter of against the rule. The goal is to end up with a spherical cornea, and you do that by targeting for a 1/2 diopter of with the rule and using the EKR65Ks and that astigmatism. Next question.
Okay, thank you. Let me see here. There's been a couple. Is there a particular application for the line graph? And I believe they're referring to this line graph
One
here.
at the bottom right there. That histogram. Yeah, well, see, that the histogram, what I was trying to show was go back to the presentation and let me show that again. Okay, now click on, go up there, not on that map, but go up a little higher where it shows 3 of them. Yeah, right there, slide 28.
You still have control, by the way, too.
Yeah, that slide 28 shows you what I'm talking about. This is that same histogram. And so the point is, the broader that histogram, remember that's what it looked like in that PMD patient, that the histogram basically shows you the spread of corneal power, and it's directly related to your ability to hit the bullseye for a refractive target following cataract surgery. The wider this is, the harder it is to hit the button because you've got so much corneal power variation from 32 to 45. You'll never get that on a bullseye for an RK. But when it's 41 to 44 and you got a peak like this, you ought to be able to hit that on the button. So that histogram is a distribution of the corneal power over the 4.5 millimeter zone. And if that thing is very wide and quite varied, then it's proportional to the multifocality of the cornea. The wider that zone, the more multifocal the cornea, and the harder it is to get a perfect result, and the higher the irregular astigmatism. All right, next question.
Okay, so can you explain the chord length mu value and the effect it has on refractive outcome?
Absolutely. Let's go up and look at that. Let's take a look. Go up to number 25. Yeah, that's a cone, but that's okay. Now let's look at that for a minute. All right. Now, when we look at that value up here, all right, let me put that up on the screen so we can see it good. All right. Chord length mu, this value right here, is the distance from the center of the pupil to vertex normal. In other words, it's where the light reflex appears to be relative to the center of the pupil. Now, if you remember when we were residents and you looked in, you'd look at the pupil, you'd hold the pen light up, and you'd say, gee, that light reflex is about 0.3 of a millimeter nasal to the center of the pupil. And that's normal. That's what it should be. So this is a normal 0.3 right here. Now, what happens is, if that value gets to be over 0.6, then the center of the pupil and vertex normal, which is where the visual axis is, are so far apart that when you put a diffractive multifocal lens in there, you want it centered on the pupil and you want it at vertex normal, and those two are so far apart that you get poor optics and patients complain of waxy vision and they don't get good performance. So all chord mu is the new name that Daniel Chang and George Waring IV published in the AJO last year, or year before last, and they call what we've always called angle kappa and gave in tenths of a millimeter, they called it chord mu, but it's the same thing. It's the distance from the center of the pupil to the light reflex, and if that's more than 0.6 of a millimeter, then you better be careful because diffractive multifocal lenses will not perform well. And that comes from a paper from Arkerwall and another paper that was done by the Czech Republic, both of which show that if it's over 0.6 of a millimeter, patients complain of glare and halos and suboptimal results with their multifocal lens. Next question.
Okay, thank you. Does the Barrett calculator adjust for back surface power? If so, do we still use EKRs?
Well, that's a good question. Graham just came out with an article, it was October of this year, last month, or the month before last. And he did a study where he used the Holladay 2 and he used the IOL Master and he used the Barrett calculator and the Holladay calculator and some other calculators. And what he showed was that the you actually have to download the article online because the journal didn't put the right figure in there. It's actually called figure A, and you have to go online to download it. But what he showed is what I said was telling you before. He showed that with the Holladay calculator, the Barrett calculator, all of those calculators, he showed that you have to include a half a diopter of against the rule to adjust for the drift and what's going to happen to the cornea over the first 6 months. And so the Barrett calculator in the article, they adjusted that half a diopter of against the rule. And so theirs was on the bullseye, but the size of the confidence interval was no different than it was for the Holladay for any of the other things except for a combination that I don't remember. But the point is, if you adjust for a half a diopter of against the rule that happens from that healing after surgery, by targeting for a half a diopter of with the rule in your calculation, then you'll end up on the button and end up with almost all of your patients within, it'll be up around 80% within plus or minus a half a diopter. So there's two ways to do it. When you look on your toric calculator, you find the toricity that gives you a half a diopter of with the rule astigmatism, half a diopter of plus axis 90, okay? Plus axis 90 is with the rule, that's your target. Or the other way is target for 0 and subtract a half a diopter from with the rule and add a half a diopter against the rule, and you'll get the same outcome. Next question.
Okay. So I think we'll probably take a couple more and then wrap it up if you're okay with that.
Yeah, no. Whatever you guys want to do.
Okay. Let's see here. Can you use EKR 65s for all IOL calculations?
Yes, absolutely. That's the whole point of that. I have many users of the Holladay IOL Consultant that use nothing but the Pentacam for their measurements, the EKR 65. And the only adjustment that they make when they use the IOL Consultant and the Pentacam is that they target for 1/2 a diopter of plus axis 90. They target for a 1/2 a diopter with the rule. And those people come out with about between 50 and 75, actually over 80% of their patients have less than a 1/2 a diopter of astigmatism, post-op residual.
Okay, perfect. Let's see. If the pupil is not central, should the Ks be used to should the Ks be centered on the corneal apex or center of the pupil?
Well, you don't have any control of that. Basically, what happens is Ks are always taken at vertex normal, which is where you're you're perpendicular to the cornea and you're along the visual axis. So you always want to take your optical measurements on the visual axis because that's what the patient's seeing. So if the pupils, what we were talking about is, and it relates to that thing about the multifocal lens. In some patients, the little black, the little white reflex and the chord mu will be somewhere between 0 and 0.3 of a millimeter in 90% of your patients. All right. So K readings are always taken at vertex normal, and that's very close to the visual axis, and that's what you want to know the corneal power of. You want to know the corneal power along the visual axis. Now, if the pupil's decentered to a large angle kappa, so that that chord mu is very big, you can still get good results, and you'll still get good astigmatism results. But what will happen is the diffractive performance requires that your pupil's concentric with the rings, and it also requires that that central ray is perpendicular to the optic. And if they have a large angle kappa, you can't get both of those. It's either if you push it over to the visual axis where vertex normal is, now you're perpendicular to the lens, but your pupil's way over. So the diffractive optics aren't balanced. And if you push it over to the center of the pupil, well, then what happens is that central ray is not perpendicular, so you can't win. So the point is, if it's less than 0.6 of a millimeter for chord mu, then it's safe to do it for diffractive lens, but you always want to take the K readings in the normal manner, and that is with the patient fixating on the target of the instrument, and you want to take the measurement with it taking the zone of the cornea that's aligned with that visual axis. So you can't adjust that anyway, but the fact is you always want the K readings on vertex normal, and that's what every single instrument of topography, tomography, keratometry, and everything else, they all do that. All right, one more question.
Okay. Last question here. I think a lot of these have doubled up, but let's see. Where do you find out what kind of spherical aberration an IOL induces? How did you know the Tecnis lens induces negative spherical aberration?
Well, okay. So the Tecnis aspheric lens is minus 0.27 microns of negative spherical aberration. That's what they have in their labeling. That's what's in their package insert. The Alcon lenses are about minus 0.18 microns of spherical aberration, and the B&L lens is made spherical. So basically, when you get that total SA up in the middle, right up here, and click to a slide that's, have I still got control of that? Yeah. Have I got control of that?
Yes, you do, Dr. Holliday.
So can I get to another picture? Well, anyway, so can I get to another,
Yeah, let me get you.
yeah, advance to one that's got a value up there. So basically, I know that the Tecnis AMO lens is minus 0.27. I know that the Alcon lens is minus 0.18, and I know that the B&L lens is 0 for their wavefront IOLs, their aspheric IOLs. So when I look up in this upper little box here, like this patient is 0.472 because he's post LASIK, well, I know that the highest negative lens, which is minus 0.27, is going to be best for this guy because he's got so much positive spherical aberration. But you'll have people that are down at minus 0.15 and minus 0.18, and you'll have people after hyperopic LASIK that are down around 0 or negative. So you match the three values of the lenses that are available to the value that you get for the patient up here for his spherical aberration.
Okay.
Any
Thank,
more hot questions that looks like we haven't covered?
I think that everything has been covered. We've had some double questions, so I
Okay,
think
good.
we'll just wrap it up. I really do appreciate your time and that excellent presentation, Dr. Holliday. I have this last slide here. If anybody missed any part of the webinar or wants to look at any of the other webinar recordings from Oculus, we do post them to our website at oculususa.com. If you have any questions that didn't get answered or you didn't get the chance to ask the question, you can contact myself at coflaherty@oculususa.com or our service department at service@oculususa.com. And you can contact us if you are not on the current Pinacam software and you want to get updated to the new Pinacam report. If you want the Holladay interpretation guidelines, you can contact me with that. I will be sending everybody the Holladay interpretation guidelines, everybody that's attending here. But
And Chris, can they get the PowerPoint presentation from you that we just showed at the end there also?
sure, yeah, I will go ahead and include the PowerPoint presentation. So if you want to review that, then you can do that at your leisure.
Wonderful. Well, listen, I just want to thank the people that have listened in tonight because I realize how hard it is to do on a Wednesday night after you've worked. But I really do think that this is going to help you in your practice and get better results for you in both cataract and refractive surgery. So thank you, Chris, for having me.
Thank you, Dr. Holliday. You have a good night, and everybody out there, please have a good night.